topic, and that is color in cylinder. One must know the color of gas cylinders, anesthetic gas cylinders. So I think oxygen cylinder is pretty easy. Everyone must be knowing that. So black body and white shoulder. Apart from that, uh, black cylinder is for nitrogen, blue is for nitrous oxide, and brown is helium. Okay, this is color of oxygen cylinder. Now, next question is about AMBU bag, which is also known as artificial manual breathing unit. Now, if we are using AMBU bag alone, what amount of oxygen is delivered? So, if we are using AMBU bag alone, it delivers around 21% of oxygen. Now, this is the image of AMBU bag. This is how AMBU bag like artificial manual breathing unit. Now, if we are using AMBU bag alone, it will deliver 21% of oxygen. But if we are using it along with the oxygen reservoir, we will be able to deliver 100% of oxygen, right? So this depends on fact whether we are using AMBU bag alone or along with an oxygen reservoir. Now, just an additional fact, amount of oxygen delivered when we do mouth to mouth breathing, this is only 16, right? So remember these values, and these are very important from exam point of view. AMBU bag alone 21%, AMBU bag along with oxygen reservoir 100%, and mouth to mouth breathing 16%. Then moving forward, another question, and it is about the delivery of FiO2, which is fraction of inspired oxygen. So the device which delivers FiO2 between 24 to 40%. Now this is the standard nasal cannula, because we have two types of devices. One is low flow and another is high flow. In low flow, the oxygen delivery cannot be regulated, but that can be regulated with high flow devices. So standard nasal cannula is a low flow device, and it delivers FiO2 in 24 to 40%. If we discuss about face mask, which is also a low flow device, it delivers somewhere between 35% to 60%. Then Venturi mask, which is a high flow device, it delivers about 24 to 50%, and the non-rebreather reservoir mask delivers FiO2 in 50 to 90%. So for standard nasal cannula, this is somewhere between 24 to 40%. This is a table which you need to just memorize. Then moving forward, a patient with road traffic accident, and there is maxillary and mandibular fracture. Now he is having respiratory distress. What is the immediate method to secure airway? Now, since there is fracture of maxilla and mandible, means upper jaw and lower jaw are fractured, and therefore we cannot do any procedure which demands opening of the mouth, like especially like oropharyngeal intubation or even nasopharyngeal intubation. These procedures cannot be done here, and the best out of all the options is, of course, emergency tracheostomy, right? So in cases of fractures involving the jaw, best method to secure airway is tracheostomy. Then coming to endotracheal tube, as we pass it, then obviously we encounter some resistance. So, which component of the endotracheal tube determines the resistance while intubating the patient? This is, of course, the width or the diameter. So, that determines how much resistance we will encounter as we pass on the tube. Now, Murphy's eyes, this is one of openings, or you can say one of the feature of endotracheal tube, and this is meant to continue ventilation even if the tube. So this is Murphy's eye here. Right? So this is a component of endotracheal tube. Then this is very important question, and this is about the positioning of the patient while doing endotracheal intubation. Like what should be the position of the neck while doing endotracheal intubation? Now, when we are doing endotracheal intubation, we have to align the airway, and the position is like we have to flex the neck and we have to extend the atlanto-occipital joint, and this position is referred to as like sniffing the morning air. Right? This position is referred to as sniffing the morning. So the neck is flexed and atlanto-occipital joint is extended. So this is proper position while doing endotracheal intubation. So flexion at the neck. So flexion at the neck and extension at the atlanto-occipital joint between C1 and the base of occiput. Flexion at the neck and extension at the atlanto-occipital joint. Please remember that. And this is the classical sniffing position in the patient, and this is just a maneuver to align the airway and to ease the process of intubation. Okay, so this is very important and it has been asked many number of times. Then moving forward to some essentials in anesthesia, and there is one grading system, and that is ASA grading, that is American Society of Anesthesiologists grading. Now, as per this grading, there are 5 grades, and what is the meaning of grade 1? Now, in most of the grades which we discuss in medicine or surgery, here at those places, actually grade 1 is taken as very mild kind of pathology, something like that. But here in anesthesia, grade 1 has nothing to do with any abnormal. So grade 1 suggests that the person is healthy, right? So please remember this, because many times the natural tendency is that the moment we find the word grade 1, we always presume that there might be some mild systemic disease. But this is not the case with American Society of Anesthesiologists grading. ASA grade 1 means the person is absolutely healthy. So this is the grading here. Grade 1, the person is healthy. So ASA physical status classification system, grade 1 healthy, normal healthy patient. Grade 2 is patient who is having mild systemic disease. This is grade 2. Then simply grade 3 will become severe systemic disease. Grade 4 and will have a severe systemic disease which is a constant threat to life. And grade 5 is a moribund patient. Moribund patient means about to die. So a moribund patient who is not expected to survive without surgical procedure. And grade 6 are actually is a separate class which actually is meant for persons who are coming for organ donation. So this is grade 6. It's a separate thing. So is already a brain dead patient, and here the main purpose is organ retrieval, organ donation. Clear? So this is 6 is not live patient yet. So these are the grades as far as ASA, that is American Society of Anesthesiologists. And again, I am repeating, grade 1 means absolutely normal and healthy. Okay, please remember that. Then I think there is no exam which can will be completed without putting a question from Mallampati grading. That is very important from exam point of view, and one has to be very well versed with this particular concept. So Mallampati grading, this is used to assess difficulty for endotracheal tube insertion. So in Mallampati grading, we assess the oral cavity and we expect like whether we will facing some difficulty while intubating the patient, and what are the landmarks which we actually see here. So you can simply you can remember it by the mnemonic push, right? You can remember it by the mnemonic push, and this is just a simpler way of keeping in mind. So P is for partial, U is for uvula, S is for soft palate, and H is for hard palate. So these are the structures which we really visualized while examining the oral cavity. So suppose if we are able to see only hard palate, then that's the most we can expect a most difficult intubation. So here remember the mnemonic as push, fascial pillars, uvula. So you see here, this one is the tonsil. Okay? The tonsil here. Anterior to this is the anterior fascial pillar, and posterior to this is the posterior fascial. Okay? This is the posterior fascial pillar here, and this one is the anterior fascial. So these are the fascial pillars. This is uvula, right? This is the tip of uvula. This is soft palate, and this is hard palate. Clear? So these are the structures which we usually see during doing Mallampati grading. Now, hard palate, as the name suggests, it is made up of bone. Soft palate, the name suggests, it is made up of so hard palate, soft palate, uvula, and fascial pillars. So based on this, let us take one question. And here, while doing adequacy of mouth opening, that is Mallampati grading, fascial pillars were visible. Now, fascial pillars were visible. And when we say fascial pillars are visible, it means we will be seeing hard palate, soft palate, uvula, and then only we will reach up to this area. So it means we will be seeing all the 4 structures. So here this becomes grade 1. Clear? So this becomes the grade 1. So in grade 1 or class 1, we can see all the 4 structures, that is mnemonic. Clear? So we can see the fascial pillar, and you can see here anterior pillar, posterior pillar, anterior pillar, this posterior fascial pillar. We can see the uvula, then you can see the soft palate, hard palate. So EUSS. You can see all the 4 landmarks. This is Mallampati class. Okay. Now Just one more question to strengthen the concept. If only soft palate and hard palate is visible, what will be the class? So here again we will go to the image and we will see what is being given in the question. So we can see soft palate and we can see only hard palate. So S and H is class 3. So here answer will come out to be class. Clear? So if you can see all four, this is class 1 or grade 1. If you can see only 3, the uvula, soft palate and hard palate, you will say that this is class 2. If you can see only soft palate, hard palate, this is class 3. And if you can see only hard palate, means it is going to pose difficulty while intubating the patient. So this is how you can remember, and very hopefully questions will come from this, right? So please remember this Mallampati grading, and this will really help you in exam. Now, which nerve is used for monitoring of neuromuscular blockade in anesthesia? Now, we basically monitor ulnar nerve for monitoring neuromuscular blockade, and the muscle which is commonly checked is adductor. Clear? So this is the nerve and this is the muscle which is being monitored to check neuromuscular blockade. And if the ulnar nerve is not given in options, then you can also search out common peroneal nerve amongst the either ulnar nerve, common peroneal, right? So these nerves are commonly employed for monitoring of neuromuscular. Then moving forward to general anesthesia, and here a patient was undergoing some surgical procedure under general anesthesia, but suddenly he developed tachycardia, that is increased heart rate. There is sweating, hypertension, and tachypnea, increased BP, increased respiratory rate. Now, what has to be done here? Now, this all features suggest that there is light anesthesia. So, what we need to do? We have to deepen the plane of anesthesia. So, this all suggests light anesthesia. So, we need to deepen the plane of anesthesia, right? So, this is how we can solve this. Now, one of the inhalational anesthetic agent is halothane, and it should not be repeated again within a period of 3. So if a person has been given halothane within a period of 3 months, then it should not be repeated. At least there should be a gap of 3 months between repeated administration of halothane. And there is one important complication related to halothane, and that is known as halothane. Halothane causes decrease in cardiac output. And if we check nitrous oxide also can cause minimal effect or can cause even increase in cardiac output, and sevoflurane will cause depression in cardiac output. So this is how isoflurane is the one which is preferred in cardiac patients because it does not affect cardiac output much. So isoflurane. So the cardiac output will remain more or less same, and therefore you can remember the word iso. Tells like same. So that way it's just a keyword to help you remember that isoflurane is preferred in cardiac ailment patients because it does not alter cardiac output. Yeah, so this is isoflurane. Now, one inhalational anesthetic agent which causes maximum respiratory depression and it is contraindicated in epilepsy. Now, it is contraindicated in epilepsy means it is epileptogenic, can precipitate epileptic fits. So, this is enflurane. So, enflurane is epileptogenic. Clear? So, now how to remember it? You can remember E from epilepsy and you can correlate it with E of enflurane. Right? So, enflurane can cause epilepsy, therefore, it is contraindicated in a patient who is having a history of epilepsy, and it also causes maximum respiratory depression. This is N. Okay. Then, if we can just take like halothane, we already discussed that it causes halothane hepatitis. Then sevoflurane, it is sweet smelling. Now this point is very important because sevoflurane is least pungent, means is least non-irritating. Okay, so it is least non-irritating, it is sweet smelling, and therefore is preferred in children or pediatric age group. Yeah, so this is why we prefer sevoflurane in pediatric age group because it is least irritant and is sweet smelling. So child they accept it very easily. Then next question: which inhalational anesthetic agent has rapid onset of action and rapid recovery? So starting of action is very quick and termination of action is very quick, and therefore it is desirous for day care surgical procedures, and call it OPD procedures. Now this question is about inhalational anesthetic agent, not intravenous, because if the word is intravenous then your answer will become propofol. Now this is inhalational and this is desflurane. Okay? So this is desflurane. So now how to remember this? You can take the word rapid. Clear? And rapid, from rapid you can write as, okay, this is S, right? So rapid onset, rapid recovery, remember the, okay. So we have discussed three inhalational anesthetic agents. Isoflurane, less effect on cardiac output, the cardiac output remains same, that is iso. Enflurane, epileptogenic, E for enflurane, E for epilepsy, and rapid ends with D and desflurane starts with. Okay. So these are some tricks how you need to remember the agents, otherwise there is a lot of mixing up. Clear? Now here we can just take few words about desflurane. And desflurane is used for day care surgery, and we also already discussed because of fast onset and recovery. Okay? So this is preferred for day care surgery or OPD procedures. And what is written? Induction recovery is fast, and for remembrance you can use the word rapid, and G for desflurane. Clear? So this is how you can remember it. Now identify the agent with a blood gas partition coefficient similar to nitrous oxide. So blood gas partition coefficient. Now this means solubility of anesthetic agent in the blood. Now here let us see the blood gas partition coefficient of nitrous oxide first. So for nitrous oxide it is 0.5. Okay? So it is 0.5 for nitrous oxide. For ether it is 12. This is for desflurane it is 0.4, right? For isoflurane is 1.4, and for halothane it is 2. So these are the blood gas partition coefficient for different inhalational anesthetic agent, and if we compare, we can say that nitrous oxide blood gas partition coefficient is somewhat similar to desflurane. So more or less similar. Right? So blood gas partition coefficient for nitrous oxide is somewhat similar to desflurane, and yes, if desflurane is not there in the option, you can mark sevoflurane also, because for sevoflurane it is 0.6. So that is somewhat closer to nitrous oxide. And in relation to this blood gas partition coefficient, we can correlate one more fact, that those which are having low blood gas partition coefficient like desflurane 0.4, its onset and induction and recovery is very quick. Similarly for nitrous oxide, the blood gas partition coefficient is 0.5, so its induction recovery is very quick. And for sevoflurane also, the blood gas partition coefficient is 0.6, so it is also one of the fastest acting inhalational anesthetic agent, right? So three agents are having fast induction and recovery: nitrous oxide, desflurane, and yeah. So this we need to remember. Okay? So here in this question also, in 17, question number 17, we see that there is no mention of sevoflurane or nitrous oxide, and therefore answer can be easily taken as desflurane. Okay? Otherwise, nitrous oxide and sevoflurane also have the same property as that of desflurane. And now, what is this blood gas partition coefficient, which is written as lambda? Now, if the blood gas partition coefficient is less, it means the anesthetic agent is poorly soluble and it will diffuse easily from lung to blood or to brain. So it is easily diffusible, and therefore the recovery is quite fast, poorly soluble, right? Whereas if the blood gas partition coefficient is high, it is highly soluble, and therefore the recovery will be delayed. Okay? And this we can again see in this table. If we take the example of ether, the blood gas partition coefficient is 12, and therefore it is taking long time. Its recovery is very slow because it is highly soluble, and therefore recovery takes a lot of time. So blood gas partition coefficient actually indicates what will be the rate of recovery, whether it will be fast, whether it will be slow. So the inhalational anesthetic agents which have a low blood gas partition coefficient, they will have a fast recovery, and vice versa. Clear? So please remember this much. Then moving forward to next question, which inhalational agent is delivered by special vaporizer? This is again desflurane. So we give desflurane by a special vaporizer. Okay. Then moving forward to another question. This we have already discussed. Which inhalational anesthetic agent is preferred for induction, especially in pediatrics or children? The answer will be sevoflurane. And the reason I have already told you why it is preferred, because it is sweet smelling, it's non-irritating, so the child, they don't have any objection. Now, fastest acting inhalational agent. Now here again, instead of fasting acting, you can use the word rapidly acting. But see in the option, because whenever you get this word fast acting, you can use the word rapid, right? And for rapid, I told you, remember, desflurane. But along with desflurane, you have to remember two more options. One is sevoflurane and another is nitrous oxide. Now, since in this particular question, none of the option is desflurane, so we will go with the answer sevo. Okay, so here the answer will be sevoflurane, which is also having a low blood gas partition coefficient, means recovery is going to be very fast, and it is almost similar to desflurane. So it depends on the options. If desflurane is given, mark it. If it is not there, you can also go with sevo. Yeah. So these two are important uh, as far as such type of MCQs are concerned. So either remember desflurane, or if it is not there, then you can remember sevo. Now, which of the following anesthetic agent is contraindicated in intermittent porphyria? Now, in cases of porphyria, never give phenobarbital because they can precipitate the attack. So, never give thiopentone. So, in intermittent porphyria, never give phenobarbitones or thiopentone. Now, which of the IV anesthetic drug acts on NMDA receptors, N-methyl D-aspartate receptors, NMDA receptors, and this is ketamine. So the intravenous anesthetic agent which acts on NMDA receptor is ketamine. So for ketamine, we can remember few important keywords. Of course, one is that it is NMDA receptor antagonist, N-methyl D-aspartate receptor antagonist, but the effects are very important to discuss for ketamine. One is that it has a tendency to increase all pressure. When I say all pressures in the body, can be blood pressure, can be intracranial pressure, and it is intraocular. Clear? So it has a tendency to increase all the pressures body, the blood pressure, intracranial pressure, and intraocular pressure. Now, how you will take these facts? Suppose if the patient is hypertensive, then don't give ketamine because person is already hypertensive, and we know that ketamine will cause increase in blood pressure. So in a hypertensive patient, there will be furthermore increase in the blood pressure, and that is not acceptable. So in a case in which the blood pressure is already elevated, is already high, don't give ketamine because it has a tendency to cause increase in blood. Similarly, if a person is having raised intracranial pressure or raised intracranial tension, maybe because of trauma or because of some space occupying lesion like tumor. So the intracranial pressure is already high, and if you give ketamine in such a case, you are going to increase intracranial pressure even more. So the patient will end up in trouble, right? So this is few correlations. Now, just based on this facts, we can discuss some indications. Like, it is indicated in patients who are having hypotension, because the patient is having hypotension, and we know that ketamine will increase blood pressure. So if we give it in a case of hypotension, or you can say shock, hypovolemic shock, the blood pressure will increase, and that is in one way good for the patient. So this is how we can correlate this fact uh, practically, that it increases blood pressure, it increases intracranial pressure, and it increases intraocular. Now this is one thing. Now there are certain terms which are related to ketamine. One is dissociative anesthesia. So the patient is has gained consciousness but is not moving limbs. So dissociative anesthesia. Then, as the patient is coming out of the anesthesia, there will be emergence reactions, can be hallucination, and the other thing we have already discussed. So these are few terms which you should remember: dissociative anesthesia and emergence reactions, especially hallucination. This is very important. Okay? And so, if someone asks you which anesthetic agent leads to post-surgery hallucination, that is emergence reaction, I think the answer is pretty clear. It is ketamine. Then the next question: which IV anesthetic agent causes cerebral vasodilation and therefore increasing the intracranial tension or intracranial pressure, and increases cerebral oxygen consumption and metabolism? So here again the important keyword is raised intracranial tension or raised intracranial pressure. So we just discussed that it is because of ketamine. Ketamine is the agent which will increase intracranial tension by causing cerebral vasodilation, and therefore it will increase cerebral oxygen consumption and metabolic rate as well. Now, one more question based on the same fact: agent of choice for induction in a patient with shock. Which IV anesthetic agent is preferred in a patient with shock? Now we know that in shock there is hypotension. Okay? So there is hypotension, and ketamine has a tendency to increase the blood pressure. So if we give ketamine in such a case, the blood pressure will be increased, and that is beneficial for the patient. Okay? So in cases of shock, we preferred ketamine. And one more thing, ketamine is also bronchodilator. Therefore, it is also preferred in cases of asthmatics. That is one more thing about ketamine. Then, a lady presented for medical termination of pregnancy in daycare facility. Now, here, which IV agent is the induction of choice? And in case of intravenous anesthetic agent, the induction of choice is propofol. Right? So this is propofol. And regarding propofol, we can discuss few words. One, it is anti-emetic. Clear? And it is having rapid onset and recovery, and therefore it is preferred for daycare. So if there is any question about IV anesthetic agent, daycare surgery always mark propofol. And there is one good thing with propofol, that it does not increase intracranial tension as compared to. So this is propofol preferred for daycare surgery. Now, which of the following intravenous anesthetic agent is not a cardiodepressant? It does not suppress cardiac activity, and the one which is very, you can say, cardioprotective, it is etomidate, right? So etomidate has minimal cardiovascular depression. Etomidate has minimal cardiovascular depression. But one problem, right? One problem with etomidate is that it can suppress adrenal gland. So there is adrenal insufficiency. So it suppress adrenal gland, and therefore, if patient is having adrenocortical insufficiency, don't give etomidate, because it has a tendency to inhibit steroid synthesis. So etomidate is contraindicated. Never give etomidate in a case of adrenocortical insufficiency. If there is already suppression of adrenocortical status, don't give etomidate, because it will further worsen the problem. So this is one important thing which you should remember for etomidate. Of course, one another thing is that it has minimal CV, cardiovascular depression. Then for propofol, I think we can just take because this is one which we have already discussed, that it is anti-emetic, it has egg extract, and this is agent of choice, take care. Then which drug is used for reversal of blockade by non-depolarizing cell vaccine? So non-depolarizing muscle vaccine, and these are actually competitive muscle relaxants. And here, what we need to do, we have to increase the action of increase the amount of acetylcholine at a synapse, and that is how we can reverse the effect of non-depolarizing muscle relaxant. So what we will do, we will give neostigmine, and neostigmine will act by inhibiting one enzyme, that is acetylcholine esterase. So it will inhibit acetylcholine esterase. And what is the effect of this enzyme? It is actually causing destruction of acetylcholine. Okay? So it is causing destruction of acetylcholine. So if we inhibit this enzyme, we will be minimizing the destruction of acetylcholine. So the level of acetylcholine will increase synapse. Okay? So this is how neostigmine will reverse the effect of non-depolarizing muscle relaxants, which are actually competitive muscle relaxants. Clear? So this is how neostigmine will bring about the reversal of effect of non-depolarizing relaxants by inhibiting acetylcholine esterase, which has the tendency to metabolize or to destroy acetylcholine. Then, as then administration of succinylcholine to a paraplegic patient resulted in dysrhythmia, conduction abnormalities, and finally cardiac arrest. Now, whenever we are giving phenylcholine, there is one important complication which one should remember. And one of the important complication is tendency to cause hyperkalemia. It has a tendency to cause hyperkalemia, raised serum. Okay, this is one of the complications. Therefore, we should never give succinylcholine in a patient who is already predisposed to hyperkalemia. Clear? Because if there is already possibility of hyperkalemia, and if you give succinylcholine, which is bound to cause hyperkalemia, there will be fatal hyperkalemia, and that fatal hyperkalemia can cause conduction abnormalities and finally cardiac arrest. So this is because of fatal hyperkalemia. Now, what are those conditions which causes hyperkalemia and where we should not give succinylcholine? So, conditions which can cause hyperkalemia are burn patient. There is damage to the cells, intracellular potassium is released into the circulation, so there is hyperkalemia. Then tetanus patient, paraplegic patient, crush injury patient. So, in all such cases, we should never give succinylcholine because these all are also causing hyperkalemia. Succinylcholine is also supposed to cause hyperkalemia, and there will be fatal hyperkalemia. This is very important. The moment you find the word paraplegic, succinylcholine should not have been given, but if it is given, it is bound to cause fatal hyperkalemia, which will cause conduction abnormalities and even cardiac arrest. So this is because of hyperkalemia. In such cases, don't give succinylcholine. Now, this is one of the favorite questions of exam setters. Drug which is undergoing Hoffman's degradation. And I think most of you must be knowing the answer. This is Cis-atracurium. So Cis-atracurium, it goes spontaneous degradation, right? So there is spontaneous degradation, and see, this is independent of any involvement of liver or kidney, right? So therefore, the for Cis-atracurium, the primary excretion is insignificant, in the sense it is not dependent on liver or kidney, and therefore if a person is having any liver pathology or any renal pathology, it can be given in persons with liver and renal pathology, because we know that excretion has nothing to do with the status of functioning of liver and kidney. Okay, so this is one important thing about Cis-atracurium. It has no, there is no role of liver or kidney in its excretion. Now, atracurium is not preferred as such, and instead we prefer Cis-atracurium, because if we look here in atracurium, one of the problem is release of histamine, and histamine has its own effect like flushing or anaphylaxis kind of reaction. So this is the problem with atracurium. Atracurium causes histamine release, can cause flushing, other changes. But this is not the case with Cis-atracurium. So Cis-atracurium is not releasing any histamine, and therefore we prefer Cis-atracurium over atracurium. Okay, so this is one more important point. So Cis-atracurium is preferred over atracurium because there is no histamine. Fine. Then moving forward to regional anesthesia, and one question is about like which is the most commonly used agent for intravenous regional anesthesia. So this is IVRA, and this is also known as Bayer's, block or intravenous regional anesthesia. And here we prefer lignocaine. Options given, we prefer lignocaine, and remember bupivacaine is never given because it is highly cardiotoxic. So bupivacaine is contraindicated in IVRA or Bayer's block. So we prefer giving xylocaine, that is lignocaine. Now, a patient became unconscious after giving an intercostal nerve block. So whenever we are giving any block, obviously what we are doing, we are injecting local anesthetic, right? So we are giving local anesthetic. Now sometimes what can happen, this local anesthetic can develop systemic toxicity, and that condition is known as the local anesthetic systemic toxicity. It can come there, and patient can have seizures, neurological manifestations. And now what to do in such a case? One of the methods is to give 20% lipid emulsion. Now it acts as a lipid sinker, so it tries to minimize the effect of the local anesthetic. So this is 20% intralipid emulsion. This is very important if there is local anesthetic systemic toxicity, that is last. So one of the step is 20% intralipid emulsion administration, apart from other resuscitative measures. Then moving forward to epidural anesthesia. So all of the following structures are pierced during epidural anesthesia except, now see, the word is epi. Now epi means, so it means the anesthetic agent is deposited above dura mater. Dura mater is not punctured, because if we just have a look at anatomy, so as we go from skin to inside, the last structure is actually the, like if we are giving spinal anesthesia, we puncture the dura mater and arachnoid mater. Say if this is dura mater, deep to this will be obviously the arachnoid mater. This is the arachnoid mater. Okay. Now if the needle deposits the anesthetic agent above the dura without puncturing it, this is known as epidural anesthesia. And if the needle punctures the meninges, that is dura mater and arachnoid maters, and reaches into the subarachnoid space, this is spinal anesthesia. Okay? This is epidural. Okay? So this is the basic difference between epidural and spinal anesthesia. Now the question is about epidural procedure. It means The needle is stopping well before the durameter, right? So it is stopping well before the durameter and the arachnoid matter. Arachnoid matter plus durameter. These are not punctured. The needle, it deposits the anesthetic agent well before the durameter. Clear? So this is not punctured, and yes, all the ligaments like interspinous, supraspinous ligaments, they are punctured to reach up to desired spot. Now here, this is the location supraspinous ligament, the supraspinous ligament. Then this one is the interspinous ligament, and the innermost is ligamentum flavum. Okay? So obviously these structures have to, these ligaments have to be pierced. Spinous, spinous, like this. So this is epidural anesthesia, and it does not puncture the durameter. Now, what is the basic difference between epidural and say spinal anesthesia? In epidural, which is a technically demanding procedure, there is a catheter which is left in place, and therefore if we wish to prolong the duration of the anesthesia, we can give additional anesthetic agent and we can prolong the duration of surgery, which is not the case with spinal anesthesia. In a spinal anesthesia, whatever amount of anesthetic agent you have injected once, you have to finish the procedure within the effect of that amount of drug, and if you fail to finish the procedure within that duration of time, you have to supplement with general anesthesia. So one of the advantage with epidural is regarding time anesthesia. Here we can extend. Yeah, so it can be extended in epidural, but it is fixed in spinal, and it depends on the amount of drug injected. And second is, since there is a catheter which is left at the site, so through that we can give analgesic agent. So post-operative analgesia, because the patient is complaining of pain, we can give the analgesic agent through that epidural catheter. So post-operative analgesia is possible with epidural, but it is not. There is no concept of giving post-operative analgesia since there is no catheter in place. So these are the two things. And third is, yes, technicality. Yes, it needs some expertise, but this is very simple. Spinal anesthesia is one of the commonest type of anesthesia which we see in clinical practice. Okay, so these are the two basic differences between epidural and spinal. And yes, if we talk in terms of durameters, like arachnoid as durameter, we can say it is not pierced. Here we will write is these meninges, they are pierced. So these are few differences between epidural and spinal anesthesia. And if the question is about epidural, it means we will not pierce the durameter, because we are not going into the subarachnoid space. We have to stay above the durameter, that is in epidural. Okay? So again, if the question is about correct sequence of structures which are pierced by the needle while giving epidural anesthesia, obviously there should be no mention of durameter and the arachnoid matter. So starting from outside, very first structure is of course the skin. Very first structure is the skin. Then second is venous. Then comes the ligaments, spinous, intraspinous, ligamentum flavum, right? So we go like that: skin, subcutaneous tissue, supraspinous, interspinous, and ligamentum flavum. So this is the order. And yes, if the question is about epidural, then after ligamentum flavum, you can add dura mater and arachnoid. So this is how the ligamentous anatomy you can remember. Now, this is the spine, the spine of a vertebra. This is the vertebral body, and the ligament which connects the tip of spines is spinous. The ligament which is present within the spines is interspinous, and the ligament which is deeper to interspinous is ligamentum flavum. Okay, so this is the order of the ligament. Outermost is supraspinous, then interspinous, and innermost is ligamentum flavum. And remember, there are two ligaments which are related to the vertebral body and they are not at all pierced. So this is of course anterior. So in relation to vertebral body, the one which is on the anterior side running in a longitudinal manner, so this is anterior longitudinal ligament, and the one which is lying posterior to the vertebral body running longitudinally, you will call it posterior longitudinal. But these are not at all discussed during giving anesthesia. So the only territory is supraspinous, interspinous, ligamentum flavum, and obviously after that there is meningeal. Then moving forward to another question, a case of uterine fibroid was planned for hysterectomy, and she was found to have severe cardiac problem. Now, which procedure should not be done in such a case who is having cardiac ailments or cardiac problems? Now, whenever there is any cardiorespiratory issue, don't do laparoscopic procedure, because what we have to do in laparoscopy, we have to inflate the abdomen with carbon dioxide. We have to create that pneumoperitoneum kind of thing, and that will compromise actually the cardiorespiratory status of the patient, right? So if already the patient is having cardiac ailment or cardiorespiratory issue, better don't do laparoscopic. So in cases of cardiac disease or COPD, there can be problems if we do abdominal distension, if we create pneumoperitoneum, right? There might be breathing difficulty, there might be cardiac problems as such. So in laparoscopic method should not be employed in cardiorespiratory problems. That is one of the, you can say, relative contraindication for laparoscopy. Then which of the following is not preferred for giving anesthesia when we are planning for cesarean section in a case who is having severe pre-eclampsia? Now, if the lady is having severe pre-eclampsia, what we do, we prefer regional anesthesia. Right? Regional anesthesia is preferred. When I say regional anesthesia, can be spinal, can be epidural, or it can be combination. So combined spinal epidural. Okay? So these are the procedures which are preferred in a lady who is having severe eclampsia. So either try spinal, either try epidural, or a combination after the two. And general anesthesia is not preferred at all in a case of severe preeclampsia. It's always prefer regional anesthesia. Okay? Now, a child was undergoing surgery for squint, and during the surgery there was a sudden fall in heart rate from 140 beats per minute to 40 beats per minute. Now, as an anesthetist, now there is one term like surgery is being done on eye, and what is happening? There is affection of heart because there is reduction in heart rate. So this is oculocardiac reflex. So this is oculocardiac reflex. Whenever surgery is being performed over eye or whenever there is a pressure over the eye, that will reflexly lead to a fall in the heart rate. There will be bradycardia. This is the oculocardiac reflex. So what you need to do, simply stop the procedure for a while and let this reflex be abolished by itself. Right? So you have to stop the surgical procedure time, and this reflex will go away by itself. So there is no problem as such. So this is just a low cardiac reflex which has developed because of surgical procedure eyeballs. This is oculocardiac reflex leading to bradycardia. Then moving forward to another question, and this is a very important segment, cardiopulmonary. So out of the four options, we have to select which points are true in relation to high quality. Now, number one, chest compression at the rate of 100 to 120 compressions per minute. Yes, right. So this is one thing. Then depth of chest compression should be between 5 to 6 centimeters. Yes, this is also true because we know that it should be around is 2 inches, so that will come around 5 centimeter. And one of the important points is that allow complete chest between compression. Allow the chest to come back to its position before trying another compression. Right? So these three are very valuable points. And fourth one is not true. Ventilation at the rate of 20 to 24 breaths. No, it should be around 10. So it should not be that much high. Out of these all, these are the few points which you should remember. Rate of chest compression should be at least 100. Depth of chest compression should be at least 2 inches, that is 5 minutes, 5 centimeters. Allow chest to recoil completely after each compression, then only after go for next compression, and minimize interruptions in chest compression. Means it should be continuous, and avoid excessive, in average 10 a, not 20 to 24. Excessive ventilation. So this is features of cardiopulmonary resuscitation. Now moving forward, one very clinical question, like a patient having gunshot injury and he is now hypotensive, pressure is now the doctor has planned to give rapid infusion of IV fluid. So which colored cannula he should use? Now here the thing is that the patient is hypotensive. It means is all less. So we need to give large volume of IV fluid. And to give it at a faster rate, we need to use large bore cannula. You can say a wider cannula. And whenever we discuss the size of the cannula, the smaller the gauge, wider is the cannula. This is need to remember. This is one thing. So suppose if we are using 22 gauge is smaller in the diameter as compared to the one which is 16 in number. So there is, it's not same to same. It's reverse, you can say. Smaller the gauge, wider the cannula. Now this is in with respect to the size. Now another thing is in relation to color. You should remember the color as well. And the wide bore or the widest bore cannula is the one which is orange. Clear? And the orange color is 14. Clear? So if we just write over here, the orange color is gauge, means widest of all, most wider bore. Then gray color is thin gauge, second to orange. Then yellow color is 24 gauge, and the blue color is 20. Clear? So you can see the smallest number is for orange color, but smaller the number, wider the diameter. Remember that, right? So for emergency conditions where we need to infuse large amount of fluid at a very fast rate, we put orange color cannula. Please remember, orange color cannula, 14 gauge. So this is how you can remember. Now we can move forward to some image based questions. And one question is about central supply of gases, and here we have to answer like which gas is delivered through this blue pipeline. So blue is like, I think, very easy to remember if you can remember the blue colored cylinder also. So this is very easy for nitrous, right? So blue color is nitrous. Then oxygen is, one is white color, nitrous oxide. Then this is nitrogen, and finally vacuum. Yeah. So white color is oxygen, is white, nitrous oxide is nitrogen is black, and vacuum is, so you can remember it like blue color is nitrous oxide. This is central supply of gases. Now another question is about identifying a cart is given image. Now look here, what are the instruments in this cart? You can see laryngoscope, you can see Goodell's airway, you can see endotracheal tubes, you can see laryngeal mask airway. So all these instruments, they are actually meant for maintaining the airway. So this is an airway cart. All the instruments in the trolley, they are meant for securing airway. Yeah? So this is an airway cart. You can see laryngeal mask airway, endotracheal tubes, laryngoscope, Goodell's airway. And I think should be no doubt about this particular image. What classification or grading system is discussed here is, of course, Mallampati score on Mallampati grading. And just take the opportunity to discuss points one again. So if you can see all the four component of push, this last one, you can see only push, two, you can see only H, that's 3, and if you can see only H. So with increasing class, you will keep on removing one initial from the from this mnemonic push. P is for pillars, fascial pillars, right? Anterior fascial And then in class 2, you will see only uvula, palate. And in class 3, you can see only soft and hard. This is how you can remember the Mallampati grading. Then, while performing this procedure, which of the following structure is not? Now, this is again regional anesthesia. Regional anesthesia can be spinal anesthesia because we are looking for dribbling of CSF from the needle. So, spinal anesthesia. And as already discussed, while we are piercing the structures, we start from skin, subcutaneous tissue, interspinous ligament, then interspinous ligament, ligamentum flavum, and finally we will pierce the meninges, that is dura mater and arachnoid. And what is not approached is anterior longitudinal ligament because that is present anterior to the vertebral body, cannot be approached from behind. Right? So this is spinal anesthesia, and we do not reach up to anterior longitudinal at all. Now, what is the site of this procedure? Again, this is spinal anesthesia, and in adults, so spinal anesthesia. Now, actually, we need to understand what is the basic concept behind spinal anesthesia, and for that, we need to learn a little bit about the anatomy of the spinal cord first. Suppose if this is spinal cord, as medullaries, from here is nerve root. So these nerve roots, they look like a tail of a horse, and these are known as cauda spinal. And we all know that it's all CSF fluid. Okay? So what we actually do whenever we are giving spinal anesthesia, we don't target spinal cord. We are depositing the drug somewhere in the subarachnoid space, and we are trying to block nerve roots of cauda. Okay? So our aim is target nerve roots of cauda equina and not the spinal cord. So therefore, the place where we need to inject local anesthetic, it should be well below the termination of spinal cord. Level should be below the termination of below the termination of spinal. Now, this level of termination spinal cord different in adults and it's different in the pediatric age group, and therefore the level of giving spinal anesthesia differs in both the age. Here ends between L1 and here it ends between. So therefore, if someone asks you what is the site spinal anesthesia, what you will say? Either L2, L3, L4. We are going below the site of termination of spinal, and here I have to go L4, something like this. Okay? So this, if in adults, you can mark L2, although L3, L4. So this is the concept behind giving spinal anesthesia. Why at a lower level? Because we don't want to touch spinal cord. We are targeting cauda equina. So this is thought about spinal anesthesia. Which procedure is shown? Now, this is the classical Byers block, which is also known as intravenous regional anesthesia. This we prefer if we have to do any surgery over the hand, or in such cases we prefer this kind of anesthesia. I again I remember this repeat, don't give buvacaine, give xylocaine. Given. Yeah, this is very important. This is Byers block, and prefer giving xylocaine and not buvacaine, because that is a very highly cardiotoxic drug, and that cardiotoxic reversible also. So in Byers block, don't give UPV. Then moving forward to another question. Here, some needles are being shown here. You can see Quinky needle, Ithacan needle. Now, what is the use of? Now, while giving spinal anesthesia, there is one very common complication patient does not want, and that is spinal post-dural puncture headache, that is spinal head. What happens, like, there is, whenever we are puncturing the dura mater, there is a possibility of some leakage of CSF from that puncture site, right? So we tell the patient to please keep head end low for at least 24 hours after the surgery, and therefore even like in wards, if in the patients of spinal anesthesia, like we always elevate the foot end of the bed. So in that sense, we are just making sure that the patient does not get up from the bed, because the moment he sits or stand up, there is high possibility of leakage, and the patient will land up in spinal post-dural puncture headache. So what we do, we just try to minimize that puncture, minimize the size of the puncture in the dura mater, and that can be achieved by if we are using a very small bore needles like Quinky, Vitek, 40 needle. So these needles are mainly used to minimize dural puncture size, because we know that if the puncture size is less, obviously the chances of cage will be less, and therefore we can minimize possibility of post spinal. So the use of these needles is to minimize the possibility of dural puncture headache, which tends to come after spinal anesthesia. And other ways of preventing that complication is to tell the patient, please don't raise your head for at least 24 hours after the procedure. Let your head be down. Therefore, we are elevating your foot end. This is one thing. But despite that, if the patient doesn't listen to you, sits up in the bed or starts roaming here and there, is bound to have post puncture headache. And this headache is usually occipital in location, and that might last for 7 to 10 days. That you have to make clear to the patient. See, you don't listen to complication you're getting, right? So from our side, we can just minimize size of that dural puncture by using smaller gauge needles, pinky, we take care of. Purpose of these needles is to minimize the size of the, and that will minimize the amount of CSF. Then, so the answer here is option C, final. Moving to next question. Now, which nerve is tested to monitor neuromuscular blockade? And in one of the questions, we have already discussed this, that which nerve is preferred for monitoring neuromuscular blockade. Uh, and you can see here, this is upper limb, and classically, the answer is ulnar nerve. Right? The nerve is ulnar nerve, and if someone asks you about muscle, the muscle is adductor pollicis. Okay? So classically, this is showing testing of ulnar nerve as a method of monitoring neuromuscular blockade. So answer here is option B, ulnar nerve. Then the last question: what is the use of this instrument? Now, this instrument is a laryngeal mask airway, and this laryngeal mask airway is used whenever we are expecting difficult airway management. The answer is option A, that is difficult. This is laryngeal mask. Answer is option difficult management. So this is enough for this session. I'm very sure you have enjoyed the session. Thank you.